the Modifiable Determinants of Ill Health in the Cayman Islands, STEPS 2023 survey results, which will be discussed by three presenters. Firstly, Rachel Corbett, National Epidemiologist. In her current role, Ms. Corbett is supporting the surveillance and reporting of both communicable and non-communicable diseases in the Cayman Islands and strengthening public health capacity. She will be followed by Chief Nursing Officer Felicia McLean, who was appointed earlier this year and joined the ministry with over 26 years of experience in nursing. Passionate about nursing experience, Felicia is eager to lead initiatives to enhance professional development within the nursing profession and ensure the highest standards of patient care in the Cayman Islands. Then we will hear from Chief Medical Officer Dr. Nick Gent, who will conclude the session. Dr. Gent was appointed CMO in October 2022, and he has extensive experience working in areas including advice on legislation concerning human rights, public health, health services and health regulations, preparedness and response to major incidents, disaster relief coordination, restoring and developing public health systems, and developing healthcare services. We do have time allotted for their presentation, and if we do have time at the end, we will take questions. So at this stage, I will invite Rachel to begin the presentation. Let's welcome her.
Okay, good morning, everyone. Thank you, Ben. I am Rachel Corbett. I'm the National Epidemiologist in the Ministry of Health and Wellness. And this is my third, and for me, most exciting conference that I've had the privilege to speak at, because we are launching and sharing the results of the STEP survey with you today. And this has been a huge undertaking, but I'm really pleased that we've been able to gather national data and update the information we have with reliable information on the health status of our population. I shared some of the results last night for those of you who were here on established ill health. If you weren't able to make it, I'm told it will all be on YouTube next week, so you're welcome to take a look there if you want to. But we'll be looking at the second half today around determinants of ill health. And for me, in the early years as an epidemiologist, I focused more on infectious diseases, and there's definitely something a little bit more exciting and novel when there's the start of maybe an outbreak or an infectious disease pandemic, so much so that you've probably seen some Hollywood movies about it with hazmat suits and infections passing from monkeys to people. Maybe you've even played the ball game. But the real threat to our population is actually non-communicable diseases. This is what is happening very much in the here and now, has been for a long time, and sadly will likely be for a long time to come. But the good news is that we actually know pretty much most of the time what we need to know. We have the tools to manage and to treat, but also to prevent these conditions. So we're in a pretty solid position of knowing where to go next. Non-communicable diseases are not infectious. They're not typically passed from person to person, but are a result of behavioral, environmental, and genetic factors. We're talking about things like cardiovascular disease and diabetes. And around the world, these are the leading cause of mortality and disability. And we see this echoed in our data in the Cayman Islands, looking at our mortality data from 2021, which shows that cardiovascular disease is the leading cause of death, attributing to 27% of deaths, and diabetes being the top third cause at 10%. These also often will impact an individual's quality of life, can impair their ability to do everyday activities, maybe even stop them from working. So we really need to be doing more about trying to prevent these from happening in the first place. And to do that, it's really helpful to understand more about the risk factors that lead to them. If we know the prevalence of the risk factors, we can then target our interventions at people who are most affected by those. We can reduce the prevalence of risk factors and therefore reduce the prevalence of the diseases. We do also, as I'm sure you know, have an aging population. These diseases tend to increase in prevalence as an individual gets older and be more common. So we are looking at having a much bigger burden on our healthcare services in the years to come. So what have we been doing to understand this more? We've undertaken the STEP survey in 2023. Apologies if you were here last night. These first few slides will be a little repetitive, but just to catch everyone up to speed. This is a survey that the World Health Organization has designed. It has a standardized approach, so it can be used in many countries around the world, and then you can compare the data between those countries. It takes a random sample of the population. So we don't interview everybody, because that would be very labor-intensive. But we take a random sample, and we did this across all 3 islands here. And those that are eligible are residents, and we use the same definition as the census, so it's comparable, aged 18 to 69 years old. And it's important that we do this of taking a random sample rather than just taking data and collecting it from healthcare services, because we also really want to understand health information about individuals who aren't in contact with health services, because they are likely to have a greater burden of illness. And the last time that this was done was over 10 years ago in 2012. It's called the STEP survey very simply because it has a few different parts, a few different steps to it. The first one being a questionnaire, and we had an amazing team of enumerators who were out in the field knocking on people's doors, asking if they would take part and completing the questionnaire with them. At the same time, those enumerators also took some physical measurements, which meant that we've got some objective measures to go alongside the self-reported data. This included things like height and weight and blood pressure. And then finally, step 3. This was done at a separate occasion with a nurse, and it was a finger prick blood test, a very small amount of blood, to test for blood glucose and cholesterol. And we combine this data together from these different sources to then be able to look at some different risk factors, some of those being more behavioral, things like tobacco use and alcohol use, and some being more biological, whether an individual might be obese or overweight or have raised blood pressure or raised blood glucose. So as I mentioned, we shared some results last night on established ill health, and today we're going to be focusing on the determinants of ill health. So as you can see, this will include diet, physical activity, tobacco use and alcohol use. And then we also have some information on uptake of health screenings, which mostly relate in the data here to cancer screening, and the proportion of the population who then have more than one risk factor. I'll start off by sharing some demographic information, so looking at the individuals who took part and describing them, and then we'll jump into this section. For any of the data that I show, these are prevalence estimates because we took that sample. We haven't interviewed every single person, so the outcome that we get is an estimate. And it also has with it a 95% confidence interval, a range around that number. And generally, I haven't included these ranges on the slides. It gets a little tricky to follow, but they'll all be shown in the report. We were also able to break down the data by 2 variables, which is how we designed our sampling frame. So looking at sex, men and women, but also looking at 2 different age groups. So younger adults that were grouped as 18 to 44 years old, and older adults that was from 44 to 69 years. And so as I present the data, I'll also show measures for those different demographics, those different groups, and give an indication of whether there was a statistically significant difference between those groups, which then tells us that maybe that we need to be focusing on one of those groups more than the other. And there'll be some p-values shown on the screen. These have come from statistical tests, and the thresholds we've used is 0.05, so if the number is lower than that, then that's a statistically significant finding. Okay, so to launch right in, we had just under 2,000 people who took part in the survey. We had a pretty good split between men and women, just slightly more women at 53%. Half of the participants were black, 15% white, 11% Asian, and 8.5% Hispanic. We have some data that we asked about their household income. So this shows the amount of money that anybody in that household was earning, and that is for the whole year. And we found that 20% of participants earned less than $15,000 over the year. A further 21% earned between $15,000 to $30,000. Further 25% earned between $30,000 to $70,000, and you can read the rest there. This was quite interesting to see this breakdown, and it got me thinking a little bit around how we describe the variance and the difference in income, and I had a little look into some indicators of poverty. Now, there's no universally agreed definition, so I've taken one mostly out of curiosity from the UK, which is called the Relative Low Income Indicator, and this is purely just looking from a financial perspective. But the way that they calculate that indicator is they take the average median income of the population. They then look at what is 60% below that number, and they say anyone who falls that 60% below or lower is described as having relative low income. So I applied the same logic to data here in Cayman out of interest, and took the data from our census from 2022. So the median income from our census was $36,000 for the year, and if you go 60% below that, it comes out at just below $15,000. So taking that indicator here and applying it in this situation would indicate that 1 in 5 of our population fall into that category of having a relative low income definition of poverty. We also have some health insurance coverage data, so we asked individuals what kind of plan they had, and we found just over half, 55%, were on a comprehensive plan from a local provider. 17% were on a Synico plan, a further 17% had a standard coverage in plan, a further 5% had a comprehensive plan, but this was from a global provider and one not on island, and then finally 5% reported having no health insurance. So to launch right in to the interesting results, we're going to start off with tobacco use. So in the survey, we found that 12.5% of our population reported being a current smoker. This is that they had smoked in the last 30 days. This was more common among men at 18% than women at 6.7%. And that was a significant difference. This has decreased slightly since 2012, which is the good news. It was about 15% for current smokers in 2012. And the proportion among men has also reduced there. But it's not a huge difference, I would say. Then we've got a bit more data here describing a bit around tobacco use. So the mean age of initiation is 20 years. The mean number of cigarettes smoked per day is just over 9. 55% of those current smokers smoke daily. 55% tried to stop smoking in the past year, which I think is interesting, and that was higher among the younger age group as well. But also 28% who had been to a health worker in the last year and who was a current smoker have been advised to stop. And I think this is interesting because it's a little lower than I was expecting to see, so it definitely shows a gap where, as healthcare workers, we could be using that opportunity of that encounter more. I'm imagining it was probably for a different reason that they were there, but to be able to provide those healthcare messages at the same time. We also asked about second-hand smoke exposure, and the results showed that 7.3% of the population reported that they had exposure at home, that someone else in their home had been smoking, and this again was in the past 30 days. And 9.4% reported exposure at work, and this was higher among men at 13% than among women at 5.6%. And this is a bit of a concerning aspect for me, given that smoking is illegal in public places, but also because in 2012, this proportion, which is now 9.4%, was at 11%. So we've seen very little change in the last 10 years, despite the fact that we have brought in some legislative changes around this. So this is definitely an area that we could be doing more in terms of enforcement. Vaping, we added some questions to the questionnaire to understand the national prevalence of the use of vapes, or e-cigarettes. And we found that 8.4% of the population currently report vaping, and 60% or 59% of those use a vape daily. There were definitely differences demographically, so this was higher among men at 11% than among women at around 6%, and it was also notably higher among the younger age group among 18 to 44-year-olds at 13%, then 2.5% in the older age group. And notably, even higher, more when you combine those two together among young male adults at 16%. And it's interesting because we do have the data from the National Drug Council in the Sisters report, which is students in high school. And so to give a comparison, their findings show that for those 11 to 18-year-olds, around 8% report vaping in the last 30 days. So you can see as that's then transitioning into young adults, that prevalence is increasing. And this is the first time that we've had national data on the vaping prevalence among adults. So to take a look at alcohol use, so this pie chart here describes the status of the population falling into different categories. So the darkest color blue there shows current drinkers in the past 30 days, which is 55%. Moving around, you've then got 15% who didn't drink in the last month, but drank in the last year. A further 12% who haven't drunk in the last year, but they have drunk in the past, and then 18% who are lifetime abstainers. Just looking at some changes since the 2012 survey, the prevalence of being a lifetime abstainer was a little higher 10 years ago at 22% rather than the 18% that you see there, but the prevalence of being a current drinker was very similar. Among current drinkers, 10%, 1 in 10 drink daily. Average number of standard drinks reported was 2.6. And the prevalence of current drinking, again, does shift a bit demographically. We see it higher among men at 66%, and we also see it higher among younger adults at 61%. Now, the frequency of drinking and the quantity is really where we see the biggest health risks and impacts. So we had some questions around heavy episodic drinking, normally we refer to as binge drinking, and this was defined as having 6 or more drinks on one occasion. And this was reported by 18% of the population in the past 30 days, and again, higher among men at 25% than women at 10%. And the prevalence, again, was highest among your young male population at 30%. One thing just to bear in mind with alcohol self-reported data is it's something that we know globally is quite often underreported when you ask someone to self-report how much they drink. And some studies have looked at comparing self-reported sources to supply sources, so like sales of alcohol from shops. And the estimates typically think that self-reported data is between 40 and 60% lower than what the shops will tell you. We also had some feedback from our team anonymously, no names shared, but our team in the field of some encounters where they would go into the house and ask these questions, and the response they would get is, oh, I don't drink much, maybe one glass at the weekend, 1 unit. And they keep going with the questionnaire, and a few questions later, their partner walks down the stairs with 2 bottles, 1 in each hand, and 1 or 2 bottles tonight, love, that kind of encounter happens. So just bear in mind, these are likely the minimum estimates. Okay, moving on to diet. So we asked questions around diet, mostly fruit and veg consumption, and also some questions on salt. And we found that on average, individuals reported eating fruits on 4.7 days of the week, and on a typical day, they'd have just over 1 portion. And for vegetables, these were reported to be eaten typically on 5 days of the week, but again, around 1 portion a day. The proportion that did not eat any fruits or vegetables at all was more in younger adults at 17% and lower in older adults at 10%. So you can see then the chart on the right, the green pie chart, showing that in the lightest green color, 14% of the population overall do not eat any fruits and vegetables. And then overall, putting those other categories together, 85% eat less than 5 portions of fruit and vegetables per day. And this hasn't changed since 2012. This has stayed very, very similar. And only 14%, so we're in that darkest category there, only 14% of our population will eat greater than or equal to 5 portions of fruit and vegetables a day. So moving on to salt consumption, we asked a few different questions around this. And the first bar in this chart shows the proportion of the population who will often or always add salt when they're preparing or cooking food. So this was 60%. This is the same as the survey 10 years ago. The second category asks how often individuals would add salt or salty sauce to their food before or eating or during eating. And this came out at 12%. Again, this was the same as the survey done in 2012. This was significantly higher, around double, among younger adults at 15% than older adults at 8.5%. And then the last bar shows the proportion who often or always eat processed foods that are high in salt. And this came out at 20%. And again, this is higher in our younger population, those aged 18 to 44-year-olds, at 26%. We then have some data on physical activity. And from the self-reported data, we found that 20% of our population are not meeting the WHO recommendation of doing 150 minutes of moderate intense activity per week. And this is higher in women, with 27% not meeting this recommendation, than 13% in men. And you'll see as I show more data on physical activity, there is this trend that generally men do more activity than women. So you can see in this box at the bottom, 33% of men are not engaging in vigorous physical activity, whereas this is much higher, with 72% of women not engaging in vigorous physical activity. And this chart really just shows a similar trend. We kind of categorized the activity that was reported to us into a low, medium, and high intensities. And so men are in the dark blue bars and women are in the light blue bars. So if you look at the proportion that are doing a low level, it's much higher in women at 40%, doing a low level of activity, than men at 22%. We also asked about the settings that people do their activity, mostly around recreation, transport, and work. And what this graph here shows is the proportion who reported doing no activity at all in any of those areas. So we found that 36% reported no recreational related physical activity, no kind of sports or hobbies. We found that 75%, and this probably doesn't really surprise you, reported that they did no transport-related activity, so mostly thinking probably about commute, going to work, walking or cycling. 75% of the population do no exercise in that process. And 47% reported that they don't do any activity as part of their work. And the work indicator was also higher among women, with 55%, over half of women not doing any physical activity as part of their work. To move on a little bit to health screenings, and as I mentioned, this is mostly based around cancer screening. So we have some data here showing the uptake of screening for different aspects. So the first bar you're looking at is around cervical screening, and this is among our target population of women who are aged 25 to 49 years old. And we found that 68% had ever been screened for cervical cancer. We also asked about the recency of this, and we found that 54% were screened in the past 2 years. So looking at the gap that leaves over there, 33% of women in our target population have never had a cervical screen. Moving on to the second bar, this is looking at mammograms, and this is also among our target population, which here is 45 to 69-year-old women. And it's slightly better uptake that 80% have ever had a mammogram, so we've got that gap of 20% who have never had one. And then moving on to the third bar, this is looking at the uptake of having a prostate examination among men, and you can see that 30% of all men have ever had a prostate examination. And then looking at the older age group of men, those aged 45 to 69-year-olds, this was a bit higher at 54%. And finally, the last bar is looking at having had a fecal examination to look for hidden blood. This is a screening test that we use for bowel cancer. And you can see 19%, 1 in 5 of the population have ever had a fecal examination. This is very similar to the 2012 data, which was at 25%. In the UK, the guidance is that this is screening is recommended from the age of 50. In the US, it's a little bit earlier at the age of 45. So we also looked at the data for this in that older age group to be a bit more comparable. So among those 45 to 69-year-olds, the proportion of the population who've ever had a fecal examination was just a little bit higher at 29%, but still very low among the population on the whole. And then the final bit of data I'll share is about multiple risk factors. So we combined together whether an individual was a current daily smoker, whether they were overweight, whether they had raised blood pressure, whether they were doing insufficient physical activity, and whether they were eating less than 5 servings of fruit and veg per day. That very small slither at the top, the 2.8%, that's the proportion of the population who have no risk factors for NCDs at all. The big section you can see there of 63% is the proportion of the population who have 1 to 2 risk factors, and then a third of the population at 34% have 3 to 5 risk factors. And if we consider our older adult group, the 45 to 69-year-olds, the proportion that have 3 to 5 risk factors is much higher at 47%. So nearly half of that age group have got 3 to 5 risk factors. So just to bear in mind a few limitations to this data, whenever we look at data sources, we've got to bear in mind what it tells us and what are the things that we need to be aware of. There was quite a lot of self-reported data that I've showed you here, and there are a few different biases just to have in mind when interpreting it. One being social desirability bias. We've already touched on this with alcohol use, but that people are often a little hesitant to maybe fully share when someone's interviewing them, if there's something that maybe they feel ashamed about or they think might be an unfavorable response. This can lead to underreporting. Recall bias, we look at different time windows, and something that we ask about the last week, a respondent is much more likely to be accurate than something that we ask about in the last year. Non-respondent bias, the survey was voluntary, and it's quite possible that those that chose not to take part might have lower access to healthcare services or a lower level of health education. We did also have a slightly lower response rate for step 3, the finger prick test. So we weren't able, whilst we do still have national estimates, which is brilliant, we weren't able to break it down by quite the same level of detail as the other 2 parts of the data. And overall, mental health is not something that was included in the survey. It's a very important NCD, but we didn't feel like this was the best way of gathering that data. So just some acknowledgements while I have the chance. This was a really, really big piece of work over the last 2 years, and it was an incredible team who pulled it all off. I'm sure there might be some people in the room who actually were participants in it, and if you were, thank you so much. Your time and giving all your information in. I hope you can see how valuable this is and how we can take this forward in our public health policy and improving our healthcare services. We had an incredible team of enumerators and nurses, some of whom I've definitely seen already this morning, who were very dedicated out in the field all through the heat of the summer. So thank you for all of your efforts. We also had some excellent supervisors and core ministry team who were working around the clock beyond just the time that we were in the field over the past 2 years, pulling it all together, who did an incredible job. And we had some great technical support from Pan American Health Organization, PAHO, as well as local companies on the island who very graciously let us use their spaces for doing those step 3 nurse appointments, so that when someone was driving to work early in the morning, they could stop off en route and get that done. So thank you very much. And also to the Honourable Minister who funded all this work, and to our CEO who sponsored it and enabled it all to happen. Thank you. The full report, as well as a kind of abridged fact sheet, so it's more accessible, and hopefully some very colourful, snazzy infographics, are all going to be available on our website, www.gov.ky/steps, and this should be up for the end of November. You might also have heard there is a bit of a competition going on here at the conference. We've got some, I think there are 6 facts dotted around on some of the different sponsor tables. And in the words of our comms team, if you take some steps, learn some facts, scan the code, activate quiz mode, be accurate and wise, enter to win a prize. So we have 10 prizes available, and if you can go around, you can gather some different facts Scan the QR code and put your entries online, and you might be in to win a selection of ministry merchandise. Thank you very much for your attention, and I'll pass over to Felicia McLean, our Chief Nursing Officer.
Good morning, everyone. In the interest of time, I might skip a couple of things. We're going to go a bit fast because I definitely want you to get to Dr. Gent and some good stuff of what our policies will look like. However, as the nurse in the Ministry of Health and Wellness and my background in nursing, I'm going to take us through some of the things we can do, so modifiable changes that we can make to make a difference in our lifestyle. That's the nurse in me. So just a bit recap, yesterday we spoke a bit about the raised blood sugars, the raised blood pressures, obesity, raised cholesterol, and what that looked like. We recognized that the long-term effects of that can cause stuff like stroke, kidney failure, heart attacks, and that was kind of just educating our population as to the data that we now have through the STEPS project and what that looks like for the health of our population in the community. We are reminded that with age, these chances of getting these things increase, and so we're going to be looking a bit today at what we can do to try and decrease those.
NCD. Meet Hardy and Coco. Since they were kids, they loved the same things. All things unhealthy. As they grew up and started working, both would spend most of the time sitting behind their desks. After work, they would go out for drinks and they would party almost every night. One night, after many countless nights, it was just too much. Coco started feeling sick. Hardy told his mom Martha about Coco. Martha worried for her son
You have to go
and told him to go see a doctor. The doctor reassured him that all will be well as long as he changed his lifestyle.
My lifestyle? No!
How many of you guys can relate to Hardy? You don't have to tell me, but think about it, We're not alone as much as we look at that. It's a universal thing. All around the world, there are other countries dealing with the same thing, so much so that WHO has put together some targets in regards to the NCDs and how they want to see those be decreased in the next year. The framework is expected to drive progress in preventing and controlling NCDs, and it's looking at incorporating from laws to physical changes to economic development, the environment, and all of these things. And it's the same thing that the Ministry of Health and Wellness is looking at doing. We recently did a consultation for our National Health Strategy, and you should see that coming out in the next year sometime with just kind of plans of what we can do to improve the health and the wellness in Cayman. So healthy lifestyle changes include, as you heard earlier with our STEPS report, tobacco is one of those things that we haven't seen a big difference in regards to overall elimination of tobacco use. And we do know that that is not something we want to continue to have happen. We also want to look at moderate alcohol use, increasing our physical activity, and eating healthy. And when I say we, I'm saying we, and I want you to think two ways. I want you to think, one, what can I do myself that's going to improve my health? And then what can I do for my patients and my family and the people around me? So yesterday, you guys missed it, but Shamari threw in there that train, I think I can. And I'm going to let this kind of drive us through as we keep going, because quite often we think of these things and we think of all the challenges that we can't do it. But I want you to think, I think I can, I think I can. We get caught up that these changes are too hard to be made or it doesn't apply to us. And I want you to keep thinking about, you'll see this keep coming through. Let's see what Hardy's up to.
NCD. Hardy's unhealthy lifestyle brings his life to a halt. After recovering from a heart attack, Coco followed a radical weight loss program that he found from the internet and shared with Hardy. Hardy has spent so much energy With so little to eat, by the end of the day, Hardy could hardly keep up. The doctor put Hardy on a program to put Hardy back on track. Hardy needs to remove the risk factors around him, follow a structured exercise program, eat the right kinds of food, monitor his health. Hardy's new healthy lifestyle makes him happy, but there's trouble up ahead. From Hardy's new healthy outlook, it was easy to see that his family was at risk.
So we see that we don't want to do this alone. So as we think of, I think I can, what can I do? I want us to think about who we need to partner with as I go through some of the things in relation to things that we can change. And I also want us to think as physicians and as nurses, when we look at our clients and we say, hey, you need to change this in your diet, are we helping them or are we leaving them to go to the best friend to come with the quick fix thing that's going to make us lose that weight or be healthy? So how do we eliminate tobacco use? Definitely stop smoking. An interesting fact is some companies might sell tobacco products that look like they might be healthier for you, but there's no safe level of tobacco consumption. I'm going to say it again, there's no safe level of tobacco consumption. We need to look at eliminating that. Some of the things we might tell our clients or some of the things that we might want to do is look about planning it properly. Let's set a date. Let's be intentional. What is it going to take to really eliminate smoking if that's what we're dealing with? It's not something you just decide tomorrow I'm going to do and think it's going to be successful. You have to plan for it. Nicotine replacement therapy is also an option. It's very useful, especially if you've been in that habit for a very long time, and you can consult your physicians about it, or we should be looking at offering those things depending on when our clients tell us, I've been smoking since I was 10, telling them to quit smoking isn't just gonna happen. What are we doing with them to help it? As people are trying to give up smoking, they might wanna look at things like staying busy, replacing activities that they might have done before. They might wanna chew gum, they might wanna drink water, they might wanna exercise. We've also got a plan for the withdrawal symptoms that they might have. It's not uncommon that when you're going through this, you're going to be irritable. So we got to tell our family. We want to involve people around us. It's what's going on. We also might want to look at medication for that because the withdrawal symptoms can be really hard and taxing. So you want to talk with the physicians, or we want to give them the options as physicians and as nurses as to things that they could add to their regime. We want counseling potentially, that might be needed as well. And then long and short of it, you want to stay positive. It's not going to be an easy journey. And so encouraging people to stay positive. You might, I used it recently in another talk, you might fall down 7 times, but get up 8. Just because you failed the first time to stop smoking and you failed the second time and the third time, don't stop there. Keep going, keep trying. The benefits for your health are going to be worth it, and the benefits for our patients' health is definitely going to be worth it. So we said again, I think I can. Reducing alcohol. For this one, it's a hard one because, growing up in the Cayman Islands, this is something that we all battled with. Drinking seemed to be a pastime for what we did in the Cayman Islands, and I'm just being honest. We don't have a lot of things here for our youth to do, and even that was true from when I was growing up. And so the one thing you did was looked forward to getting old enough so you could go to the clubs so that you can hang out and you can have a drink. And there's no education as to what's a healthy level of drinking. It's just, I'm going to drink with my friends, we're drinking socially, and then we just do. And so we do see that this was an issue. Even when we had COVID, guys, one of the things that was a huge concern was how do we open the liquor stores, because we don't want the depression and all the withdrawal symptoms we're going to have because people were so used to drinking and we didn't know what we were going to do. So it's definitely something we want to look at addressing in our population. It was interesting here, I've never seen this before, but the World Health Organization had it, and it says no level of alcohol consumption is safe for our health. I know none of you want to hear it. Everyone enjoys their glass of wine with their dinner. Everyone enjoys a whiskey here and there, depending on what your taste is, but it's something to bear in mind that this is actually out there. So, going back. I went ahead too fast. So some things that we can do in regards to reducing alcohol intake is be mindful that ideally 1 drink a day for women and 2 drink for men. Believe it or not, the men do get 1 more. Why, I don't know. But they get 1 more. And so you want to look at establishing that. So when you're looking at your alcohol intake, And if we go back to the STEPS survey, we definitely don't want to be doing 6 or more in a day or in one thing. That is definitely way too much. So in moderation, look at your alcohol intake. You could potentially set alcohol-free days. So looking at it and saying, okay, well, Monday to Friday, I'm going to avoid drinking alcohol, and then maybe on the weekend I have 2. Like being wise, being smart. And yet again, when we're talking to our clients, the same thing. Give them tangible, achievable goals that they can set in regard to reducing alcohol. You want to look at avoiding triggers. If, hanging out with a certain crowd of people causes you to be more inclined to drink more, then hang out with those friends a little less. You got to be wise at looking at your situation. Change your routine if you need to. The benefits of reducing alcohol intake is tremendous in our overall health and wellness. Stay busy. And last but not least, get your family to support in that regards. Get the help from your family. Let them know that you're looking at doing these things. These are not changes that we make on our own. So including our physicians, including our family, being aware is what's going to help us. And then guess what? Technology is our best friend, both for alcohol and quitting smoking. There's tons of apps out there that you could look to give you tips and tricks about how to reduce that alcohol intake, how to measure how much you're taking, how to be mindful about it. And so use what we have and the tools that we have. And then yet again, I think I can. Physical exercise. Now this one was a hard one, guys. Hard one for me because, as Rachel said, 72% of the women are not doing vigorous activities. And I'm going to put my hand up first because I'm guilty of it as well. If I had taken that STEP survey, I'd have been in that box. I don't prioritize myself. I don't prioritize putting exercise and physical activities into my weekly schedule. And we need to stop this, guys, because it is something that we can modify. It's something that we can change. It's something that allows us to put health first for ourselves. So looking at simple things that we can be doing in that time is, first of all, focus on enjoyment. So let's see how we can put it in that's a little bit enjoyable. So yeah, pickleball, guys. We've had that in Cayman. It's a no-brainer. Go out and do that. Or I've even seen it happen in my sister's house. The kids were playing. We took out the pickleball, and in the house, because the pickleball is soft. It's not going to really damage things. We were playing pickleball in the house. Just hitting it back and forth. But it's exercise. It's activities. It doesn't have to be complicated. Walk more. I'm guilty of it as well. When I get a parking space in the mall or wherever I'm going and it's close to the door, I'm like, thank you, Jesus, I got a close parking spot. I need to be looking for the parking spot further away from the door so I can get those couple of steps in. Now, will I be hot? Will I be miserable? Yes, but I will have had some exercise, some physical activity. 10 minutes is all it takes 3 times in that day, and you've done that 30 minutes of exercise and walking in that regards. Now, yes, we could go deeper into exercise, and we can look at doing more hobbies. It was funny, an old colleague of mine, when we were outside talking, said, we were talking about weight, and we were like, it's so easy for you, it's not for me. He's like, that's because men play football, right? And we don't think about it. Us women, we don't get involved in as many sports, and we should, but that's pretty much it. It's like, what can we get involved in? What sport can we do? Guess what? The sports, joining football doesn't cost a dime. You can go get the gym membership. You can do all those things, but there's a lot of things that we can do that doesn't cost us anything that would allow us to increase exercise in our daily activities. And I think I can. And on that note, I think I can just a little bit for the exercise, and not that I'm bragging, but I'm just sharing this to say that it's doable. I've recently started working in the Ministry of Health and Wellness in the GAP building, and one of the things I've done since October, and I've done it every day, is I take the stairs. And I only see 3 or 4 people. For the whole month so far in October, I've only seen 3 or 4 people in the stairs ever. We tend to use the elevator as in case of emergency. I want you to change your mindset and think, my health is an emergency. I'm going to take the stairs. Use the stairs more often, guys. Let's just, do the small things that'll make the big differences. Diet changes that we need to look at. So basically, we definitely need to look at eating healthier. We want to increase our fruits and vegetables, and I was guilty there as well. I'd have been one of those ones with less than the 5, and these things are making me learn, and I'm making the changes as I learn all these things. I hope you guys do the same thing. I wasn't eating that, and so now I'm buying more apples, and I know that the fruits and vegetables in the store are expensive. I can't tell you any lie. That's one thing we definitely are trying to look at from a policy standpoint as to what do we do to make healthier food more affordable. But in the meantime, guys, I really want you guys to think about what you can. The apples and the tangerines, I will tell you, are probably the 2 cheapest ones. Buy the apples, buy the tangerines, buy the bananas. Bananas are high in fiber. They're things that we can be doing to better our health. And our Caymanians, I will tell you, use less salt for sure. My husband, if I try using less salt, he goes, as soon as he sits down and he takes one bite, he grabs the salt, he puts more on. And we need to be like, no, that's not necessary. We need to use more of the seasonings, as it mentions, to improve the taste of the food without increasing the salt and that kind of stuff. So small changes every day have lasting effects and benefits. Let's take one last look at Hardy.
NCD. Hardy's unhealthy lifestyle brings his life to a halt. After recovering from a heart attack, Coco followed a radical weight loss program that he found from the internet and shared with Hardy.
So now I'm going to take 2 minutes to just tag a little bit about reasons why employers should look at including it in the workplace, because like I said, it's a holistic approach that's going to take the team. If employers look at adding a physical kind of exercise or more healthier lifestyle things into the workplace, they can reduce sickness and absences by 27%. They have fewer sick days. They can increase productivity. They can reduce the staff turnover up to 16%, and they can boost morale and improve employee satisfaction. So it's definitely something that we can look at as employers to do so within our healthcare systems that set the example of you have all you healthcare workers in there. So imagine if our hospitals and our medical facilities are saying this is what we're doing for our employees, and even in regards to government, how then that sets the tone for other entities out there. So looking at something that this is a simple kind of workplace wellness challenge you could look at. Mondays, positive days. Tuesdays, drink more water. Meditation. These are things that we can do with our colleagues that would increase our overall health and wellness of our staff. Let's look at things like this. We don't even have to create it. These are just, we're not reinventing it. We're just using what we have. And so I really encourage us to look at things like that we can do. And so key takeaways: we need to decrease tobacco use. We need to increase physical activity, decrease the salt and sugars, and increase the fruits and vegetables. Decrease alcohol, and basically when you do all these things, you will decrease your chances of having NCDs or improve your health if you already have one. Thank you, guys.
Good morning, ladies and gentlemen. And somebody usually jumps up and redirects the microphones at me, so I'll remember to do that myself. And just to comment that the Ministry of Health and Wellness does take this seriously, and we have had the health and wellness sessions. But I'm missing particularly the stretching and exercise ones, which were featuring the music of a Miss Destra to encourage us all. I can't confess that I quite understood the lyrics, but it was interesting. Obviously a lady who's physically very active. Turning to the more serious side of things. Yesterday evening, I touched on the policy issues that I believe are most critical in respect to the equitable provision of healthcare. The theme of my discussion last night was about principally access to care, equitable access, affordable access, and the barrier that high-cost service provisions play in denying people care for common chronic illnesses. I used that opportunity to introduce the idea that we should look to the PAHO Hearts programme to introduce affordable care for hypertension and diabetes, especially using a wider range of practitioners that are now enabled to prescribe using our new pharmacy law, something that I want to explore and develop in this next year. Today, I want to turn to the public health policies most critical to prevention of non-communicable diseases. The key elements of the STEP survey dealing with the determinants of ill health have been very well and very ably presented to you by my colleagues. Those who know me, however, would be very disappointed if I did not start with some remarks on obesity. Obesity was the sole focus of my presentation last year. In the interim, I have seen no substantial change in the willingness, or more particularly the lack of willingness, to tackle this problem. The old arguments about fast food being cheap are still being made. More and more outlets selling harmful food products are being opened, and advertising and incentives through sponsorship by unhealthy food providers are as prevalent as ever. The lack of evidence-based conservative care options are still as problematic, and the demand from patients and healthcare providers for medical and surgical solutions are still dominating themes of professional discussion, despite our clear knowledge that without change of habit, any medical or surgical intervention will fail. I might also note that despite all the promises of the new weight control medicines, there has been little meaningful population impact of these medicines. Given the findings of the STEP survey and other sources of information, such as the school entry medical data, it is clear to me that the knowledge of what foods are unhealthy is not well established amongst our population. Information is power, and the food industry has an invested interest in not enabling rational choices. Thank you. It is time that we enabled people to make best choices for themselves and developed an enduring habit of knowing what they are eating. I would strongly recommend that the Cayman Islands adopts the CARICOM food quality labelling system. This system not only regulates claims that can be made on retail packaging, but also gives absolute clarity that a food item is high in total fat, or high in saturated fat, or high in trans fat, high in sugar, or high in sodium. Simple, clear. The next determinant of ill health that we must seek to control is the increasing risk posed by nicotine. The Cayman Islands has been a beacon of success for the control of tobacco. We're one of the few places of our size that are full signatories to the UN and WHO conventions on the control of tobacco. We must remember, though, that the tobacco companies have, at heart, never been selling tobacco. They have always been selling nicotine. And as the tobacco market in places like the Cayman Islands has shrunk, they have expanded into newer nicotine delivery systems, primarily vapes. Nicotine is not a safe drug. It is rapidly addictive. It is one of the most quickly addictive drugs on the market. Nicotine vaping has one and only one legitimate use, in my opinion, and that is as a means of weaning tobacco smokers from their habit. Whilst I can be confident that nicotine vapes are safer than tobacco smoking, I do not believe that we can be confident that nicotine vapes are safe for long-term use. And I'm very disturbed to see what I believe to be targeted marketing of vapes at children. I may be wrong, but when I see packets of disposable vapes being sold in pink sparkling colours with flavours such as bubblegum, my mind does not immediately think that the sales executive was targeting 40-year-old men as their primary audience. We must also be aware that vape manufacturers are trying to circumvent the tobacco control legislation through the introduction of synthetic nicotine to avoid their products coming under tobacco control laws. We urgently need to introduce legislation updating our current control laws to ensure that we can retain control of this emerging problem. Next, I wish to turn to some issues of cancer. I continue to be frustrated by the lack of data on cancer. I'm on record saying that any effective healthcare system must be backed by a comprehensive cancer registry. Without a registry, we cannot know the number of cases of disease presenting each year. We do not know what stage cancers are presenting at. We cannot audit the effectiveness of any screening services, and we cannot know the outcomes of care in order to be sure that people are receiving optimal care. But on a more positive note, I hope that everyone is aware that we are starting to offer universal immunisation with 9-valent HPV, human papillomavirus vaccine. This is a safe, effective vaccine. It has the potential to virtually eliminate cervical cancer in the Cayman Islands if we maintain high rates of immunization for all boys and girls for the next 10 years. Immunizing boys is critical. We will only get close to eliminating HPV-mediated disease if the whole network of potential transmission is controlled. We will also be looking closely at the National Immunisation Programme more generally to look at extending the range of childhood vaccines offered and ensuring that they are offered at optimised intervals. We are also considering our guidance on immunisation in adults, especially for those like myself of more advanced years. We are also working to develop guidance on rational screening services. For example, currently up to 8 different international guidelines are in use by individual doctors to inform their decisions on screening for breast cancer in the Cayman Islands. This is harming patient outcome, affordability, and therefore access. Our priorities are to produce rationalised guidelines on breast, colon, cervical, and prostate cancers. Not just the top-line issues of start age, stop age, intervals, and such like, but be clear on most appropriate methods too, and especially not using inappropriate, ineffective methods. There are many other concerns arising from the full STEPS dataset. I've outlined a number of key priorities that have been identified by ourselves from the Ministry, and some of the measures that we wish to take or are already in the process of actioning. Of all these issues that I've discussed, the headline actions that I would like us to take away, recognising the very important issues of significant numbers of families living in severe poverty, are the introduction of affordable systems of management of hypertension and diabetes, and enabling people to control their own health, for example, through the use of effective, simple food labelling, and protecting our children from the growing threat of vaping. Thank you.
Thank you very much, Dr. Gent, Rachel, and Felicia. Do we have any questions for coming out of this presentation? We do have some mics. We have a question here. Okay, so we have first question here. We have a second question there as well.
It's really helpful to hear about the idea of food labelling and the legislation around the affordability of healthy food here, because it's extraordinarily difficult, especially for the population that I see. Has the impact of nutrition on mental health been brought into the idea of then putting that legislation in place, and how far along is that?
The comment I made, I don't know, is this working?
Yep.
Oh, good, thanks. I'm getting paranoid about this, because every time I seem to get on a stage with a microphone, suddenly comes up and readjusts it because I've got it wrong. The overview that I gave, very simple, was, you know, there's one aspect of, but there are very many more aspects, and I was very pleased to be in a caucus meeting recently when we were discussing steps and realised there's a huge political willingness to support quite a number of issues around diet. For instance, we should be looking at things like planning controls around schools. We should be looking about differential taxation rates on different food products. You know, there is the whole issue about how well informed people are about what are best affordable diets that we need to be dealing with, and those things we need to be dealing with from the very youngest ages. I mean, these are ideally things instilled in schools, except if the school's next to a Burger King and a KFC, which does rather, you know, sort of send the wrong messages. And it seems to me that if somebody wants to open a new school, there'll be a planning application for a fast food outlet following the very next week when people know. And I think that's fairly dreadful the way that that we are not just targeting families, but targeting young people particularly. I know I made the remark last year that, when speaking to a young Caymanian, and he said he loved Cayman food, and I said, I was thinking, Cayman beef, pigtails and rice. Anybody else love pigtails and rice and beans? It's good. Come on, get yourself to Welly's. But and this kid just looked at me, I said, what do you mean? BK and KFC, and when we've got that institutionalized in young people, we've got severe problems. So using schools to change that, but hopefully getting schools to change the children, to change the parents, is also really, really important. But there's a whole raft of things that can be done there, and with imagination, and not just the imagination that's in the heads of three of us sitting here. There's loads of people can contribute to that debate. And some people know this better than others. I mean, schools, for goodness sake, are full of people who know about managing children's behaviour, educating, informing, and so on. They're called teachers, and they're real professionals at it. And so building those kind of relationships with groups like that to deliver this agenda is going to be very important.
Thank you very much. We do have a gentleman with his hand raised over here. Do we have any other questions? We may have room for one question after this, so just indicate and we'll get the microphone to you. Thank you.
Shesha Pramod, I'm endocrinologist at Indicra. Question is for Rachel Corbett. It's fantastic data there. I know that you've looked at subgroups in terms of age and sex, but do you have any data on the socioeconomic indices for fruit and veg intake and the processed food intake? I know the numbers may not be sufficient but are there any signals?
Thanks for the question. Sorry, I missed one word in your question. You said, do I have any data on something about fruit and veg intake? Sorry, I missed one. What was that word that you said there?
Fruit and veg intake and processed food intake in terms of the subgroups in relation to the incomes that you showed.
Yeah, thank you. Thank you for clarifying. So what we've showed here is very much the headline prevalent statistics, but for everybody who we surveyed, we asked about their income, we asked a broader range of social economic demographic variables than I showed. So we asked about their education status, we asked about their employment status. So for all of that, we can then dig down deeper and look and see whether there are correlations between having lower income, having less fruit and vegetables, and things like that. We haven't put all that in the report because we wanted to get the headline data out there, but that is something that we'll be digging deeper into to see if that, like I imagine you're suggesting, if there are groups who have a lower social economic status, therefore may have different health behaviours, different access, different health status to others. Definitely, we can do that.
Thank you very much, and we'll take one final question over here.
Hi, good morning. Thank you for the wonderful presentation. I have more of a comment as opposed to a question. And again, it goes along the same line of the schools and food. I think that we need to be promoting more education in the schools as it relates to agriculture. We see a lot of infrastructure going around. What about trying to encourage more opportunities for growing our own products here?
Thank you very much, and thank you to our presenters. Before I go on, I'm told that we have a quick announcement from Dr. Williams-Rodriguez.
Hi, morning. Thank you, Rachel, CNO and CMO. I just want to remind everyone of the smoking cessation program at the HSA. It has been going on for 10 years. It has been very successful. The CNO mentioned the importance of stop smoking. So you can call the number 244-2889 for more information, or you can go to the public health booth on the next door and get more information on the smoking cessation program. Thank you.
Thank you very much. And just as we wrap, we'll have one final comment from... Two comments? Two quick comments from our presenters.
Sorry, I've just been asked to remind you that the full report and some accompanying things, which will also have all of the full data tables, so you'll be able to look through and see the breakdown of indicators I've shared and many more by those different demographics, will all be out by the 1st of December on our webpage. So please do take a look there and have a look through at those details.
More comments. Sorry, this is unrelated to this particular topic, but I was also asked to share the Ministry of Health and Wellness in conjunction with HSA and some key stakeholders in the community are doing a youth event on Monday for children between the ages, the school year, between year 7 and year 12. Mental health has been a big buzzword within our community in general and definitely within our youth and young people. And so we feel it's important that we give them an opportunity to come together to share their thoughts about what they think we need to do to improve mental health and things for our youth in the island, and also take away some key bits that'll allow them to implement that in their lives, like conflict resolution and those kind of things. But then it's still a fun event. It's interactive. There's no actual talking to them. It's more along of interacting conversations, and there's an after party. So if you haven't seen that and you're interested about that, come find me, or we'll figure out how to get you guys the information so you could sign your youth up if they haven't been signed up. But we really would like our youth to attend that event. Most of them are on holidays, so it's something for them to do on Monday, and it should be a really fun interactive event at the Lion Center, all free for anyone between the ages of 11 to 18.